सुरू करा.
Uh, Good evening, respected faculties, my colleagues. Today I am going to present on the topic cerebrovascular accident and its assessment. It is actual presentation done by Dr. Gautam Jha and Dr. Mukesh Kumar Shah, third year pass out graduates, and this is my first revision of the presentation. Talking about the stroke, it is a rapidly developing clinical signs of focal or global disturbance of cerebral function with symptoms lasting more than 24 or longer, leading to death with no apparent cause other than that of vascular origin. This is the definition given by WHO. So basically, we need to concentrate into focal or global neurological sign and symptoms in a patient presenting in the emergency. And talking about its incidence, it accounts around 62% of ischemic stroke and 28% of ischemic hemorrhagic stroke. Likewise, for adult male and women, lifetime risk of having a stroke is around 25% at the age of 25 years of age. So the seriousness of stroke is increasing with our modern society. So coming to the anatomical structure of the stroke, there are two paired arteries which are responsible for the blood supply to the brain. Internal carotid artery, which is mainly responsible for anterior circulation via middle cellular artery and anterior cellular artery. And I'll be basically focusing on anterior cellular artery circulation. Basic, and another artery is the vertebral artery, which is responsible for posterior circulation, which will be covered by Dr. Sunny Shah next week. Within the brain, there is a cranial bud. The terminal branches of these arteries form an anastomotic circle known as a circle of Willis. Here is the internal carotid artery and vertebral artery. Internal carotid artery divides into common carotid artery divides into internal and external carotid artery. Internal carotid artery gives rise to middle cellular artery and anterior cellular artery, which supplies anterior circulation, and similarly vertebral artery that arises from right and left subclavian artery forms a posterior circulation. Here we can see arteries arising from internal carotid artery and giving rise to the middle cellular artery, where main tributary of middle cellular artery is M1, and further it is divided into M2, M3, and M4. Similarly, anterior cellular artery, this anterior communicating artery is known as A2, and lateral it is divided into A2, A3. Similarly, here is a vertebral artery which joins to form basilar artery. Over here, it gives rise to a labyrinthine artery. This is a pontine artery. Similarly, there are circulation of the posterior brain. Uh, Similarly, here we can see the sagittal section of the blood supply of the brain. Similarly, the circulation of the blood supply can be seen in the demarcation of the color. Middle cellular artery is represented by dark green color, whereas anterior circulation is shown by light green color in this figure. Similarly, in this coronal section of the brain, we can see the mind tributaries coming from the M1 artery. We'll be talking about the clinical significance of this artery later on also. Basically, this artery is significance of this artery is that some patient might present with the pure sensory or pure motor symptoms, and that can be quite confusing with the clinical presentation when patient has ischemic stroke or hemorrhagic stroke at distal segment of middle cerebral artery, like in M3 or M4. Talking about MR angiography in this section, coronal section of brain, here we can see middle cerebral artery. There is a occlusion at around the level of M2 segment. Here is a hypoperfusion. Here we can see internal carotid artery, and there is a tributaries of anterior cellular artery. This is the motor homunculus and sensory homunculus. Here we can see the uh, anatomical structure represented in the brain, and similarly, we can identify the clinical signs and symptoms on the basis of this homunculus. So Lateral part of the brain usually represents the face. This area is supplied by middle cerebral artery. Similarly, upper limb, torso, and lower limb. So basically, if any patient present with the facial weakness and upper extremity weakness, grossly we can say it's middle cerebral artery stroke. And if any patient presents with the facial weakness and lower limb weakness, then we can grossly say it's anterior cerebral artery weakness. Similarly, here is a lateral blood supply of brain, basically supplied by middle cerebral artery. Here, basically, I'm trying to show is that anterior to the central sulcus, it is a motor area, and posterior to the central sulcus, it is a sensory area. Similarly, we need to be acquainted with the Broca's area represented over here near the frontal region. Similarly, in the posterior region, there is a vernix area. Similarly, there is a communication in between Broca's and vernix area represented by archifasciculus, which is not shown in this figure. Here is the tributaries of middle cerebral artery as I discussed earlier, M1, M2, and M3. Talking about the middle cerebral artery tributaries, M1 is the horizontal branch supplying putamen, outer globus pallidus, posterior limb of the internal capsule, adjacent coronary data, most of the caudate nucleus. Similarly, M2 bifurcates in the sylvian fissure into superior and inferior division. M3 is the opercular segment and extends laterally exteriorly from the insula towards the cortex, and M4 is the finer cortical segments that irrigates the cortex. Here is a case that presented at our emergency. There was a 73-year-old gentleman with a complaint of sudden slurring of speech for 1 day, upper limb weakness for same duration of time, no progression or deterioration of symptoms over the time. He was a known case of diabetes and hypertension. Looking at his CT scan, this is his CT scan. Over here, we can see a CT scan, coronal segment of his brain at the level of third ventricle. Uh, Here we can see there is a ischemic stroke on the right cerebral hemisphere, and in the posterior, mostly at the posterior to central sulcus, representing a sensory area. Here, looking at the stroke, it is likely distal to M1 segment, nearly about M2 segment. This patient, on examination, had no aggravation of symptoms on standing, so we were quite in the safe zone. Uh, and patient presented after 24 hours of the event, so patient was not in the range for and thrombolysis. So talking about the middle cellular artery syndrome, it usually presents with the paralysis of contralateral face, arms, and leg, sensory impairment. Sensory impairment, motor aphasia, the inability to speak to or organize the muscular movement of the speech, if it involves a dominant hemisphere. Central aphasia is a loss of ability to understand or express language resulting from the brain lesion. Word deafness, in which there is loss of comprehension. In anemia, there is patient is unable to name out the objects shown to the patient. Jargon speech that is unrecognizable. Agraphia is known as inability of patient to write down the text. In acalculia, alexia, finger agnosia, and right left confusion is also known as Gershwin syndrome, in which there is a inability to calculate. In there is a loss of reading comprehension. Patient is not able to recognize their own finger and is confused about right and left orientation. So similarly, patient also present with the conduction aphasia, in which there is Broca's and Wernicke's aphasia. Here is another case. This image I took it from Radiopedia. Patient presented with a decreased level of consciousness with a GCS 6515 with the following CT scan of the head. In this coronal section, we see hypoperfusion at the frontal lobe. So this CT scan represents occlusion of an anterior cerebral artery. Here we see the blood supply of the frontal and parietal lobe of the brain. So the territories supplied by anterior cerebral artery are middle superior part of the frontal lobe and anterior parietal lobe. Superior and medial frontal cortex is responsible for higher cognitive functions, personality, and disinhibition, and also involves with the working memory of the person. And similarly, parietal lobe is vital for sensory perception and integration, including the management of taste, hearing, sight, touch, and smell. So, talking about the tributaries of anterior cerebral arteries, these are A1, A2, and A3. A1 from the A1 is the region from internal carotid artery to anterior communicating arteries, supplies the carotid nucleus and anterior limbs of the internal capsule, whereas A2 forms anterior communicating to bifurcation from forming the pericallosal and callosal marginal arteries. It supplies the internal capsule, whereas A3, termed as pericallosal artery, is a terminal branch of anterior cerebral artery and it anastomoses with the posterior cerebral artery. So, if any patient presents with the enterocerebral artery stroke syndrome, looking at our sensory and motor homunculus and knowing the anatomy and function of frontal and parietal lobe, this patient presents with paralysis of opposite foot and leg, lesser degree of paralysis of opposite arm, cortical and sensory loss over toes, foot, and leg, urinary incontinence, abulia meaning in no desire to speak, impairment of gait and stance, and dyspraxia of left limbs, tactical aphasia in the left limbs. Uh, 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 this difference between anterior cerebral artery and middle cerebral artery is taken from the guideline of our part on emergency ER protocol. So anterior cerebral artery and middle cerebral artery, ACA are uncommon types, whereas MCA is very common types. ACA represents 0.5 to 3% of all strokes. It is unilateral occlusion presents with contralateral sensory or motor symptoms in the lower extremity. ACA in left side lesion presents with akinetic mutism and transcortical motor aphasia, and ACA in right sided lesion presents with confusion and motor neglect. Similarly, MCA is the most common type, typically presents with the hemiparesis, facial plasia, sensory loss, contralateral side affected. Upper extremity is involved more than the lower extremity. Dominant hemisphere involvement often presents with the aphasia. Non-dominant hemisphere involvement presents in attention, neglect, dysarthria without aphasia. Uh, so, talking about the CT angiogram, this is a CT angiogram showing the vascular territories of the brain. Here we can see anterior communicating artery, similarly middle cerebral artery, posterior communicating artery, internal carotid artery, anterior inferior cerebral artery, basilar artery, posterior intercerebral artery, and vertebral artery. So in this picture, what can we see? In this picture, there is a demarcation over here. It represents there is a hypoperfusion in A1, that is a anterior communicating artery from internal carotid artery to anterior cerebral artery. So this is basically anterior stroke. Now I'll be presenting another slide of city angio. What can we see in this image? There is basically hypoperfusion of the bilateral middle cellular artery in M1 and bilateral M1 region. So if this patient had been presented in ER within 24 hours of onset of symptoms, this is a candidate for thrombolysis. So what are the traditional symptoms and non-traditional symptoms that patient might present in the ER? So these are the sudden numbness or weakness of face, arms, and legs, especially unilateral, sudden aphasia, sudden dysarthria, sudden memory deficit or septal disorientation, visual field defect, sudden dizziness, gait disturbance, sudden severe headache with no known cause, impaired consciousness or syncope, generalized weakness, altered mental status, dysphagia, shortness of breath, sudden pain in the face, chest, arms and leg, seizure, fall or accident, sudden hiccup, nausea, sudden fatigue and palpitation. So in the history, we must be concerned about whether the symptoms are waxing, waning, or static. This might suggest that the patient event is ischemic or hemorrhagic. Similarly, we must also know about the preceding incident that led to the event, like whether patient was doing any rigorous activity or was straining or doing Valsalva maneuver that might be suggestive towards the rupture of a cerebral aneurysm. Similarly, history of the recent ethnic trauma or manipulation should also be assessed. Similarly, we should know about the patient's past history, like if patient has any comorbidities or patient is under any blood coagulant, anticoagulant. Similarly, if the patient has a history of arterial fibrillation, valve replacement, or recent myocardial infarction. So in the ER, we generally use National Institute of Health Stroke Scale, which has with the score more than 12 had a positive predictive value of 83.7% with sensitivity 55.9 and specificity 89.1. So NIHS interpretation says that patient with the score 0 has less likely stroke, and patient with the score more than 5 to 15 is quite suggestive of the stroke. So similarly, another scoring chart that we use in the ER is ABCD2 scoring for transient ischemic attack, which has sensitivity of 86.7 at 7 days and 85.4 if the score is more than 4. And at 90 days, its specificity is 34 and 36.2 at 90 days. So these are the component of ABCD2 score, which includes the age more than 60, blood pressure more than 140 by 80, clinical features of unilateral weakness or speech impairment, duration of more than 60 minutes, and diabetes. So the score with 0 to 3 comes under low, 4 to 5 moderate, and 6 to 7 is under high risk stroke within 2 days of presentation. Here is another imaging of the CT MRI of M1 and occlusion. So there is a ischemic region over left cerebral hemisphere. Here is the MRI image, and similarly there is hypoperfusion in the MR angiogram of M1 in this slide. Here we can see the M2 occlusion. Here there is a PET scan, and similarly there is a MRI of the brain in which shows ischemic infarct in the left cerebral hemisphere. Any patient presenting with the stroke might have many of the differential diagnoses. So we must rule out following differential diagnosis of seizure, post-ictal paralysis, syncope, meningitis, complicated migraine, epidural or subdural hematoma, subarachnoid hemorrhage, hyponatremia, hypertensive encephalopathy, hyperosmotic coma, Wernicke's encephalopathy, labyrinthitis, drug toxicity, Bell's palsy, Meniere's disease, multiple sclerosis, and convergent disorder. This is the stroke protocol developed by our second batch and the faculties. This basically summarize all of my presentation. If any patient presenting with the traditional or non-traditional symptoms present to ER, we need to identify it as a stroke, or we need to work on its differential diagnosis. If it is a stroke, we need to do work on and treatment side by side, and if it's transient ischemic attack, we can apply ABCD2 scoring and admit, investigate, or discharge the patient accordingly. In the workup, we need to do CBC, sodium, potassium, creatinine, renal function test, lipid profile, PT, APPTT, ECG, echo, cardiac Doppler, CT8, and similarly, we need to treat the patient side by side. On the treatment section, if patient is a candidate for thrombolysis, we need to arrange accordingly. Similarly, looking at the patient CT, if it involves one vascular territory, depending upon large cortical area or small multiple recurring ischemia, we need to treat accordingly and investigate accordingly. This concludes my presentation for today. Thank you.